to introduce Max Watson, who is Medical Director of the Northern Ireland Hospice and Visiting Professor at the University of Ulster and Honorary Senior Lecturer at Queen's University in Belfast, to talk about providing better care to more people. Max is an author and editor of more than 10 palliative and oncology books with Oxford University Press, including the Oxford Handbook of Palliative Care, and has published extensively in a wide range of journals. His research interests are varied and include generalist palliative care education, cancer cachexia, dementia care at the end of life, and the use of ultrasound in palliative care. Max worked in Nepal for 8 years before completing palliative medicine training in London and Belfast. And he has developed a range of teaching programs in palliative care, including the European Certificate in Essential Palliative Care and the European Certificate in Holistic Dementia Care. He's taught and lectured extensively across the world and has been recently piloting the use of echo technology in Northern Ireland as a means of democratising medical knowledge and improving the delivery of palliative care in rural areas. He's married to Ali, a GP, and has twin sons, both in paediatric training, which links beautifully with what we've just heard. Thank you, Max.
Thank you very much indeed. Thank you. That was a very long introduction, and I would just like to say thank you to Yippee. Today I want to talk to you about ECHO, Extension of Community Healthcare Outcomes. Declarations at the beginning. We have received funding from the Health and Social Care Board in Northern Ireland. That's our health board, our NHS. The evaluation of ECHO in Northern Ireland Hospice was funded by a grant from the Belfast Charitable Society. I also have to declare that I am an enthusiast. And sometimes enthusiasts, they need the temperance of a very good senior management team, which I have in Northern Ireland Hospice. But I am utterly convinced that democratizing medical and nursing knowledge gives us, you and me in palliative care, the most opportunity that we can have for facing the demographic reality of our time. So those are my declarations. I also have to declare that I have nothing to do with the naming of this building. So what I wanted to do was to overview what is ECHO, why did Northern Ireland Hospice become interested in ECHO, how did we ECHO, what difference did it make to us, what were our outcomes. If you're interested in echoing as well, how might you do it? And then one last thing, one example, if you like, of the ECHO philosophy in action. So what is ECHO? Well, ECHO stands for, as I said, the Extension of Community Healthcare Outcomes. You could summarize it as moving knowledge rather than moving patients. Moving knowledge, not patients. 3 phrases to remember in thinking about ethics, ECHO. ECHO is democratizing medical knowledge. ECHO is tele-mentoring, not telemedicine. Great though telemedicine is, ECHO is tele-mentoring, building a community of practice. ECHO is that practice, that building a group of people who are interested and committed in one particular area, using technology as a means to achieving that great and powerful end. What's the difference between ECHO and telemedicine? Well, in a tele-echo clinic, a hub, group of professionals, group of experts, group of specialists meet using the technology with a group of generalists who have a desire for more knowledge, more information, who then in turn, because they have had access to that support and that knowledge and that peer support from each other as well, are able then to get involved in a more profound way with the target population. Telemedicine is much more, as you see there, a one-to-one procedure. I tell you about my patient, you give me information so I can go back and treat that patient. Bit of a difference. What is ECHO?
Project ECHO is a performance optimizer. Think of it as a high-speed internet connection for the healthcare system. It spreads new medical knowledge throughout the healthcare system, from university medical centres and other specialty care sites to the front lines of community care. Rather than information flowing in one direction, community providers learn from specialists. They learn from each other, and specialists learn from community providers as new best practices emerge. Under ECHO, community providers use video technology to participate in guided practice with specialist mentors. They acquire new skills that allow them to treat patients they otherwise would have referred out. Patients with complex chronic conditions get high-quality care where they live from providers they know. No waiting months to see a specialist. No long drives back and forth to get critical care. ECHO exponentially increases access to specialty care by moving knowledge instead of moving patients. Suffering and pain are reduced, and lives are improved and even saved. Project ECHO, changing the world fast. Join us at echo.unm.edu. Are you part of the ECHO?
Even though her accent is Australian, there was definitely an American feel to that video, wasn't there? But that, in essence, is ECHO. Based on 4 ideas. Multi-point video technology, okay? So it's stuff in the cloud which allows you to similar to Skyping, if you like. Much cheaper than video conferencing. I'm going to talk a little bit about the prices and the costs involved. Number 2, it's based on best practice. In your community of practice, we don't want people advocating the use of Mexican dogweed because it cured my wife's dog. You understand what I mean? It's about practice which is based on good evidence-based guidelines. Number 3, it's case-based learning. Case-based learning. If your daughter is learning to drive her car, I suggest that you don't just give her a copy of the highway code. Once she's read that, you give her the keys of the car. You sit beside her. You try and keep a calm demeanor. You try not to scream. You encourage. Because that's how we learn. We learn by practice. And so ECHO is based on the spokes presenting cases which other spokes can comment on that we can learn from together. And then we use the IT, the technology, to monitor who's attended, what outcomes have happened, and then we can provide people with CPD certificates because they've attended X number of hours of involvement in an ECHO knowledge and support network. Sanjeev Arora was the creator of ECHO. He describes how it came to him.
There is a specialist shortage worldwide. We had to innovate a new model. Project ECHO allows specialists like me to force multiply expertise. I think that's why it works, because it's very simple. And that's actually why I could come up with an idea like this, because it was simple. In 2003, there were 30,000 patients with hepatitis C in New Mexico. I didn't have enough time to see everybody. And that led to a lot of soul searching. What is the way that I can have a bigger impact than the patients whom I just see in my own clinic?
Well, the 1025 was 10.
It just came as an idea. Skype was available and talked to my daughters on it. Seeing this technological revolution unfold was probably a background knowledge that I needed to come up with this idea. In 2010 alone, we have trained more than 1,000 healthcare clinicians on our video conferencing platforms. Nurses, primary care doctors, physician assistants. Uniformly, every single echo project that we've started, the specialists find it extraordinarily rewarding sharing their expertise to improve the health of underserved populations in the United States and ultimately all over the world.
Okay. So what? Lots of us have ideas. Why should we take this guy's idea and think it's anything unusual? Well, because of this. He was a hepatologist, as he said. What were his results? What could he show that echoing actually did? Well, he was able to support rural physicians across New Mexico. And at the end of a year of echoing, specifically in hepatitis C, he was able to show that the viral loads in rural New Mexico had fallen to the same level as patients who were attending his specialist clinic in Albuquerque. At the same time, his waiting list in Albuquerque fell from 8 months to 2 weeks. And the complexity of the patients that he was looking after in Albuquerque shot through the roof. They became a lot more complex to look after because the more general patients were being looked after by generalists. But he didn't stop there. He got together the $3 million to write it up and to publish it in the New England Journal of Medicine. And with that evidence base, then this was something that we had to take seriously. What is it? Extension, to build up the strength and capacity of a community with a shared interest, to increase support for each other, to learn practically, to reduce stress for our patients who don't have to travel, to reduce stress for our staff who have access to good support and don't feel so isolated. We work with greater confidence when we are supported, don't we? We recognize that. Extension of community healthcare, locally delivered care by well-trained and supported staff. In New Mexico, they discovered that some of the rural clinics were actually doing better than the university hospital. Why? Because they were experts in the patients in that area. They had that expertise linked to expertise then about drugs and management of hepatitis C. Multidisciplinary training, multidisciplinary access is good for patients, we know that. The model that we use for ECHO is an educational governance model. So we're not dealing with specific patients, we're dealing with examples, cases presented, but we haven't generated antibodies in GPs or consultants who feel that we are interfering with their patients because we're dealing with a lady with severe neuropathic pain, as opposed to Mrs. McGuire from 43 Sloane Street, Lisburn. Okay. The model that those of you who attended here yesterday for the e-health, the gold line, I was really impressed with that, but it showed how Yorkshire people were really good at looking after Yorkshire people down the phone, supporting, in that sense, a community of practice, supporting patients, supporting carers. So this is not something which hasn't been replicated in other areas. Outcomes. ECHO gives us the opportunity to monitor progress, to monitor outcomes, to monitor the impact on staff and on patients, and that's really a huge benefit to us, particularly when we've got to go to commissioners and say what we're doing actually has an impact. So why did we in Northern Ireland Hospice become involved in ECHO? Let me explain. Well, 20 years ago, we cared for 98 patients a year in our 6-bedded unit. Today, we care for over 3,400 patients in our adult and in our children's hospices, and across the region through our community nurses. It's a different world. We currently look after 1 in 5 people who die in Northern Ireland. I think you will recognize this picture. It's an aging, older population. Margaret McCarthy, if I could quote from her, she said, in 1917, King George V sent out 24 messages to people having a 100th birthday. In 2011, the Queen sent 9,736. No wonder her lips are stuck together sometimes. Growing patient expectations. We're working before our traditional comfort zones in many ways, and there's no new money. Thank you. So why? We have 8 community teams scattered across Northern Ireland. Specialist palliative care, community, hospice, nurses. Increased complexity in the caseloads, in the patients who are being asked to treat. Year-on-year increases in numbers, 12% a year for the last 4 years. We have some vacant posts. There's also an increasing need for nurses to get CPD. How are they going to do that in rural areas of Northern Ireland? We work better with greater confidence when we don't feel isolated. That's true too, isn't it? This is something else which we all have to face. As time moves on, medical knowledge and the speed of medical knowledge improvement is increasing exponentially. What is that doing to our more isolated communities? As medical knowledge improves, it expands the definition of underserved populations. Are you with me? It expands the definition of underserved populations. The more things we do, the quicker, the more rapid the changes, the more focused those changes will be in the big centres, therefore creating more underserved areas. So we have to think of different ways of working. Here's the general practices in Northern Ireland. We have approaching 300 general practices. This is the population density across Northern Ireland, and you can see the different areas, and you can see the gaps. So this is an image of postcode lottery. How can ECHO help with that? Increasingly, we have been involved in work abroad as well. We have a vision for expanding our services and sharing what we do here with underserved populations. How can ECHO help with that? The multiplication of our impact. So, how did we ECHO? How did we try it out? Well, last year, we created a knowledge and support network through a weekly ECHO meeting, every Friday, 9 to 11, for 6 months. We thought, let's give it a go. Let's really try it and see, does it make an impact? There was a 15 to 30-minute teaching session at the start, PowerPoint presentation, followed by 2 to 3 case presentations from the spokes. The hub was at the hospice with the multidisciplinary team. The spokes were at each of the 8 community hospice teams, and the curriculum for the training was set by the spokes. It was what they wanted to learn. The power in an ECHO community of practice doesn't lie in the hub telling you what you need to know. It doesn't lie in the spokes in them asking for everything that they want. It lies somewhere in between. It's a community of practice. So the hub included a consultant, pharmacist, social worker, community nurse, GP, allied health professional, chaplain, the spokes, the other community teams. We use templates to present cases. So these are sent out to the teams. They fill them in according to if it's their turn to do the case presentation. They're sent in a few days before the clinic takes place, and they're vetoed to make sure that there's no identifying factors, and then they're sent out to the teams before the clinic. The software we use is called Zoom. It's free for those involved with ECHO. It's excellent. It's kind of like Skype with bells on. It's really slick, uses small broadband width, and we're using it for all sorts of things now in our hospice. We have an All-Ireland Institute, and we're using Zoom a lot to make contact with our brethren in Cork and Limerick and Coleraine. It just works, very simple. And the iECHO is with it to administer it and to keep track of all those who attend. These were the list of clinic topics that our spokes asked us to teach on. And that's what we went through in our 6 months of ECHO networks. This is what it's like at a spoke. We use this particular little camera because it's got a microphone in it, it's got a speaker in it, so there's no feedback system, and it allows you to have 4, 5, 6 people clearly seen on the screen. You can use your iPhone, you can use your laptop, you can use your handheld device also, but you need to be a bit intimate if there's 4 or 5 people scattered around an iPhone. We don't need to do that. So this is what we have out at the spokes. This is what we have at the hub, 2 big television screens and a clever piece of kit with a camera on it. Okay. What did it cost? Well, we had our 8 PCs with their 8 cameras, our 2 television screens at the center, and that special magical microphone, camera, speaker thing. And it all came to £12,000. Not a huge amount, and it could have been done cheaper. But that's what ECHO in Albuquerque recommended, and that's what we did. This kit, even 3 or 4 years ago, would have been $250,000 in terms of the technology of that time. So it's now very affordable for us. All the ECHO networks are recorded, so if you don't attend, you can go under password protection and have a look at the clinic that you missed last week. Here's an example. This is an example from the teaching.
So a bit of objectives. So we're going to have a little look at a bit of background, just with regards to epilepsy, and then specifically focus on seizures in palliative patients, review some of the therapy options, and some considerations that are worth thinking about.
Speaking about drugs, in case any of you have difficulty with a Northern Ireland accent. Okay. Some of you will have noticed a strange man in the foyer yesterday afternoon between 2 and 4 shouting at his computer. What I was actually doing yesterday was our first time of echoing to 17 nursing homes in Northern Ireland. The clinic was between 2 o'clock and 4 o'clock. I was facilitating it, as you do, from Liverpool. So that's what was happening, and you can see there the nursing homes. This is what we were doing.
She has the right to refuse treatment. She has the right to refuse information as well, so we should respect her decisions. And the mom's symptom.
Can I just add, in Cherry Valley, actually, we nursed a lady like this quite recently.
Yeah.
And, you know, she was very aware of her diagnosis. She was very aware of where it was going. She did not want any discussion. And in the end, we decided that all we could do was make sure she was aware that we were there to have the discussion if and when she chose to do that. And in the end, she didn't, and she went into hospital and died in hospital. So, you know, she had the capacity, and we couldn't force the conversation on her.
I think you've hit the nail on the head, and sometimes we can beat ourselves up. We beat ourselves up if we haven't had the conversation with somebody, then we beat ourselves up if we have the conversation with somebody, and then they become distressed, and we feel like we're putting the devil in the deep blue sea in this sort of circumstance. But here's where our knowledge of the individual patient is so...
Yeah. Again, you might get a detect there a little bit of Northern Ireland accent, but that's what we were able to do from the ECHO arena here. So it's very workable, intuitive technology. So what difference did ECHO make to us in the hospice? So we ran the 6 months evaluation. This was the first time we'd evaluated an ECHO service outside of America. We wanted to see what difference it made for our nurses and what their experience of the ECHO time was. We did a short pre-ECHO evaluation, a survey of perceived challenges, a clinical assessment, knowledge-based, knowing what we were going to cover in our curriculum. We did a focus group then around the ideas about the value or otherwise of echo. And after 6 months, we repeated the same assessments. We got ethical approval from the University of Ulster. And then, after each echo network, we had a short online evaluation which helped us understand what was happening and what we needed to change. And once we got that feedback from each of the nurses involved, that went onto their record, so that we built up an account of the number of hours that people were involved in echo. So at the end of the 6 months, they got their CPD certificate. Our outcome measures, we based these on the knowledge assessment and self-efficacy tool, on the local framework and local guidelines, and we evaluated the tools, piloted them first. So that's what we did. What did we show? Well, there was 34 community hospice nurses involved. 28 completed the echo evaluation, 2 left, and 4 went on maternity. Maternity, yes. What were the knowledge results? The average knowledge score improved by 11.3%, which was significant. 2 participant scores did not improve, 26 did. Knowledge improved. Pre-echo, post and retro pre-echo self-efficacy. How confident did you feel in, how confident do you feel about managing this sort of situation, that sort of situation? They all improved. What do we mean by retro pre-echo? Retro pre-echo is asking people after the echo event, before echo, how confident do you think you were? After echo, how confident do you think you were? And we do a retro pre because sometimes people's looking backwards, that they know now what they didn't know. So it's just a way of checking that out. So we show significant improvement in self-efficacy. What about opinions? 96% reported gains in learning. 89% felt that echo had improved the care they provided. 23 of 28 would recommend echo to others, etc., etc. 20 out of 28 were keen to continue to participate in echo sessions, and 68% wanted the future of echoes to be reduced in frequency a little bit to monthly, which is what we did. What about the focus groups? 4 key themes. People really liked it for continuous learning. They valued the experience that gave. There was nervousness about being on television for the first time. They stressed the importance of the facilitator skills, having the facilitator there in a non-threatening environment. Echo land is a non-judgmental land. It's a safe place. We felt that we really had arrived in echo when nurses were willing to talk about difficult things that happened as opposed to just presenting their successes, and then getting the support from other nurses from other teams. And we really felt that we'd created a community of practice. Second benefit, we really appreciated echo because it recognized our role, and suddenly we realized there was over 30 of us out there facing the same stuff, and actually what we were doing was pretty fantastic. And that sort of sense of, actually, we are shifting some diesel here was, is that a, no, okay. Experiential learning. People really felt that they were learning practical stuff. Third, challenges. There was difficulties with timing. Am I echoing when I should be with patients? Concerns about being judged initially, but those quietened down. And then emotional challenges. Some of our nurses, when they were presenting, became emotional as they relived the patient experience. But our impression of that this was much more cathartic than it was disturbing. And there was the support there from the team for nurses. Future strategies. They saw real potential for using the Zoom for all sorts of ways within the hospice to save people from traveling, and also as ways of involving the cardiac team, the respiratory team, the diabetic team, and linking in with them without increasing the mileage. What were the strengths? Well, because we employed all the nurses, we could really encourage them to participate in the evaluation, so they did. The limitations were that we used the same knowledge assessment before and after. We muddled the questions up a little bit just to try to make it not quite so repetitive. And we didn't actually do what Sanjeev Arora did, go back and see what impact it was having on patients. We didn't have $3 million to do that. We are waiting for this paper to be published. We hope it will be published soon. Okay. So, bottom line, our echo outcomes. I think it supports the further use of echo in the palliative care setting. Further evaluation is needed to consider what impact it can have for patients and for carers. And at a time when healthcare providers are under pressure to do more and to spend less, echo at least provides a potentially affordable option to addressing this growing need. What do we do actually practically? Well, we are now echoing on a monthly basis to our community teams. We've decreased the frequency at their request. We went back to New Mexico and we have trained to become the first super hub in Europe so that we can train other echo hubs. If you're interested, we can be involved in helping you develop echo without you having to travel to New Mexico. And the Northern Ireland government really saw it. I'm sorry, New Mexico is quite a nice place to go to. Northern Ireland government saw what we were doing and they really identified with it and they got behind it and they gave us some money to run and evaluate 5 additional echo networks. So this is what happened. This is why the Northern Ireland government thought that echo was worthwhile. So you can see why they saw that echo actually really fitted with their agenda, and it gave us an access to the government that we'd never had before in many ways. They were coming to us to help them because they saw us as an organization which actually do things much quicker than they can do it in government land. And so we've been involved in setting up 5 echoes, 1 for endocrine, 1 for nursing home and palliative care that I just showed you. Long-term eye conditions, so we're echoing to Specsavers about glaucoma and macular degeneration. I know nothing about glaucoma and macular degeneration, but senior ophthalmic surgeons, they are using our kit to do the teaching and to do the whole echo stuff. We have a GP trainee echo about dermatology, linking with the Northern Ireland Medical and Dental Training Association, agency rather. So we're linking to 26 GP trainees. And perhaps most excitingly of all, with our colleagues from other hospices across Northern Ireland, we hope to establish within the next few weeks our first carers echo, where we're linking carers from the hospice in Foyle, the hospice in Antrim, the hospice in Newry, and ourselves, carers from those, in a group together, supported not by doctors, but by carer coordinators, to provide that support and that knowledge that the carers want. This is quite radical stuff. It's not medically led, it's going to be carers led. And we're just making the technology available to create a community of practice for carers. We don't know what we don't know here. This hasn't been done before. But we think it's what the carers, certainly, that we've spoken to, are really keen to be involved with. This is our new hospice. It's getting close to the end we open up in the springtime. And this is our new Echo Suite, the research and education building. And we hope that this will become a place where many people will come for echo training because we think it's really relevant. Internationally, we've been involved as well with the Aga Khan Foundation, working in Afghanistan, Pakistan, and quite a few other countries ending in stan, promoting the use of echo. I wouldn't survive any length of time in the Swat Valley in Pakistan. I don't have a beard. But echo can link the Aga Khan University Hospital in Karachi with all the rural palliative care community services that exist across Pakistan. It's a real potential. This is Rajesh Gongal. He is a doctor from Nepal, and we're involved with Rajesh in a project in rural Nepal where we're trying to support village health workers to deliver better palliative care. Echo can really help with this. Handheld devices, you can get one for $50. And then connecting to a palliative care doctor in the city, an hour, a couple of hours a week, there is real potential for supporting. You're with me. This is a few months ago in Uruguay. We went to Uruguay encouraging the use of echo. Echo is now taking place on a weekly basis in Uruguay. Palliative care hospital section, the Marcel Hospital, is now echoing to 25 palliative care clinics across Uruguay, providing that support and that knowledge for otherwise isolated palliative care teams. What about you? Are you interested in echo? Does it float your boat? Is it something that could be useful for you? Here's some resources. Obviously, this presentation will be made available online. You can see those. Just a couple of days ago, our website went online. This is all happening kind of quite rapidly. We have to set up and establish the 5 echoes for the Health and Social Care Board and have it done by March. So it's a bit breathless. But if you're interested, echonorthernireland.co.uk is the website, or you can send us an email at info@echonorthernireland.co.uk. We wouldn't have got as far as what we have got, our hospice in Northern Ireland, without many people's contribution and support. I've got to say a big thank you to the senior management team at the hospice who have coped with my enthusiasms, but have also measured them and calmed me down at times. The project team in Albuquerque have just been fantastic. They have shared absolutely everything in true belief in the philosophy that we are building a community of practice that can impact on the lives of 1 billion people by 2025. It's about sharing, it's about working together. The Health and Social Care Board and the Public Health Agency have been just fantastic. They've seen the vision and got behind it. Our education team in the hospice have been brilliant as well. They're just running. It's amazing what can be done when you've got a very fixed timeline and you've got a little bit of money to make things happen. And our partners, in GP land, in medical education, nursing home land, in optician land, in dermatology land, our hospice colleagues. It is great to live in a country where hospices are working together to support each other and support these sorts of initiatives. Really grateful to them. And I must say thank you to our man in a van, who's Namek Sagi, who even as we're speaking is traveling around the roads of Northern Ireland installing webcams wherever he can. One last thing, and this is because Ross asked me to mention this. We've been talking about community of practice. Our education team in the hospice in Northern Ireland would like to invite some of you, all of you, to become part of a community of practice in terms of delivering improved end-of-life care for people with dementia. This has been a huge interest in ours. Why? Because a third of the patients who come into our inpatient units have got significant cognitive impairment. I suspect it's the same for you. And so 2 years ago, we created an 8-week home study certificate in collaboration with our care of the elderly colleagues and our old age psychiatry colleagues. And we've been running it now for 18 months, every 6 months. It's gone really well. How do I know it's gone really well? Because our staff went through the pilot. And after our staff went through the pilot, the volume of haloperidol, levomepromazine being used to manage challenging behavior completely almost disappeared. Suddenly, challenging behavior became something different. Rather than, why has this patient got challenging behavior? What are we doing to challenge this person and make them do what they're doing? So we believe in this as a mode of education. It's linked us up with our psychiatry colleagues, and it's addressed a real need. We're looking for partners, for people who would be willing to work with us to run this program in your own centres, to get the money involved in doing that, so it's will help with your finances. But it's because it's something that we want to do in this concept of sharing good stuff, and maybe we can share some good stuff from you in turn. Finally, I want to share one little video, and if you remember nothing else, just remember this video. Some people think that Echo is all about the tech. It's male jewelry, if you excuse the sexism. I'm sure females are just as into it. But it's not about the tech. It was never about the tech. It is about working together in a collaborative way. It's about the team.
Emma. Huh? Emma. 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 Emma.
Milieu de café laxifant, vraiment pédange.
Okay. Thank you very much indeed. Thank you.
Max, thank you very much indeed for a very interesting talk. I bet all of you are thinking about opportunities to use Project Echo. I'm, with your permission, going to take a couple of minutes out of your refreshment time, just so we've got an opportunity for you to ask some questions. There are some roving mics, but if you're feeling brave, there are two fixed microphones. If you would like to come down to ask a question, and if you tell us where you're from and then ask your question, that would be super. Oh, yes. Would you like to go to the mic? Oh, right. While you're moving, we've got mic 1 here, so.
Philip Lomax from St Anne's Hospice in Manchester. I'm a medical director in Collycott Guardian. I wonder if some of your exec team put obstacles in your way around information governance and servers being outside European economic communities and things like that. I wonder if you could just give us some insight into how you overcome those problems.
Great. Thank you very much indeed. A really helpful question. Did you all got that? The governance issue, the software that we use is all encrypted. So Zoom is specially designed, so upwards and downwards it's encrypted. The governance model that we use is an educational governance model. So we're not actually using patient data at all. So it's an educational governance model. Our hospice team were pussycats in comparison with the Health and Social Care Board, the government. And they were much more concerned with exactly the issues that you raised. But what made the big difference for them was, as I said, the educational governance model, but secondly, the stringency of the American system. And the fact that ECHO had been running in the States for nearly 10 years without any violations of HIPAA, which is the American equivalent. So they were kind of reassured by that. And that's how we managed to do what we have been doing.
Thank you.
Chief Executive for Highland Hospice. As you know, Max, I think we're already pretty sold on the principle of ECHO. The Highlands has got exactly the geography and issues that I think ECHO would support. We're dabbling in a number of different sort of digital solutions, but certainly for that expanding knowledge, I think ECHO just sounds perfect for us. However, as you say, the technology is the easy bit. I mean, the technology is actually quite simple. It's there. It's the people side that can be more complex. Now, you mentioned your community nurses dotted around Northern Ireland. I just wonder, how critical is that for you, having your community nurses? We have a situation where we don't have community nurses dotted around the Highlands. We do have community teams that are employed by the NHS that potentially we can echo into. I just wonder how you feel about that, how critical it is for your teams to be out there.
Thank you very much indeed. ECHO is completely agnostic about which software package you use. It's not about the tech. It's about exactly the issues that you were raising about working with a team. But you saw also today us echoing yesterday to we actually have 27 nursing homes signed up to ECHO. That's a tenth of all the nursing homes in Northern Ireland. We own none of them. They are so enthusiastic. They're more enthusiastic than our own nurses to participate in this. And you saw something in that video which was happening, which is kind of the subtle bit. You're actually seeing the creation, if you like, of a care home university, a community of care homes talking to each other, learning from each other, supporting each other, not in competition with each other. So, no, our experience has been, we were very fortunate in being able to evaluate and encourage people to go to the pre-ECHO evaluation for our nurses and the post-ECHO evaluation. But we've done exactly the same thing with the nursing homes. They've been willing to participate. We've done exactly the same thing with the GP trainees. We've done exactly the same things with Specsavers. They all sign up to the concept, because if you work in Gairloch or more remote in the Highlands, having access to somebody who does a similar job 100 miles down the road and access to somebody who's got specialist knowledge is such a valuable commodity. So go for it, is what I'd say.
Thank you. Any other questions?
Hi. Hi Max, it's Catherine Sleeman from Cicely Saunders. Thank you very much for your presentation. You mentioned that you haven't really started to evaluate ECHO, your local palliative care ECHO, in terms of patient outcomes. And I wondered, well, two things. First of all, how important will that be? Maybe it's enough to simply look at how well supported the staff feel. That's a valid outcome in itself. But if it is important to get information about how ECHO is making things better for the patients themselves, how are you going to go about trying to measure that? Because we don't have something as easy to measure as viral load in palliative care.
No. I don't have the answer to that. And I think what I've got a lot of confidence from is because I know that patient evaluation has taken place in a rigorous manner in the States. So I know that through the use of ECHO, that actual viral loads in patients in Albuquerque has improved. So if I can just prove, or if we can just prove that ECHO works in the healthcare professionals, then we can kind of look back to that and say, well, if this is all happening, then we can assume, I know assume is dangerous, we can assume that there are some good outcomes. But we heard from our colleagues yesterday in the e-health section from St. Luke's, working with their apps, and I think Oak is now available, or coming soon to be available on an app. And if we have access to patients and they are scoring themselves, there is potentially in the future the opportunity of the nirvana that we make an intervention and we can see some impact. So what sort of impacts may we see? You know, our health board haven't got involved in ECHO because they think it's a nice, fluffy idea. They've got involved because currently we're really understaffed endocrinology, we're really understaffed neurology. They're thinking of ways of working with GP federations to support a second tier so that we'll connect all the GPs with a special interest in neurology from the 17 ICP areas. We'll give them all the support so then GPs will start referring to other GPs to get instant access to a generalist neurology service. But they really want that to be evaluated in terms of impact on central outpatient clinics. And that's challenging because you need a year at least of ECHO to be running before you will see a trend in those clinics coming down. But we need your help. We need to do this together. But what an opportunity for palliative care to be involved at the outset of this and to maybe to help in other areas of medicine. Thank you.
Thank you. We've got time for one more question. Anybody? Oh, yes. Would you like to come down to the microphone? Thank you.
I'm a trustee for Oakhaven in the south. I mean, very laudable work, but the thing you haven't told us, which, you know, if we were looking to be a hub, is how much this all costs. And I suspect, yeah, you 12,000 for all the kit. That by no means is the end, is it? Because you've got to run your IT. Presumably you as an enthusiast, being cynical, looking at the trips you've been on, clearly you've devoted a lot of time to this. Can you give us an idea of what the cost of setting up a network would be?
Thank you very much, and a really helpful, useful question. You're right, the kit is not the big cost. The big cost is the commitment of your organization to send somebody for a 3-day training in ECHO. The paperwork, the software, all that stuff is provided. ECHO is a not-for-profit organization. So if you came to Northern Ireland, for example, for ECHO training, and you have to go to a centre for ECHO training, you can't just start to do ECHO. Why is that? Because the kit isn't the key bit. The key bit is learning how to facilitate. The key bit is building that community of practice. ECHO would be destroyed by an egotistical, kind of authoritarian leader crushing people within ECHO space. You know, it's about developing those skills for facilitation and building the network. So 3 days away, that's significant. Training, Northern Ireland Hospice, we will charge what it costs us to put on that training. We're not going to be using ECHO to make profit. And ideally, we would be seeking funding from external organizations to pay for this. When we went to Albuquerque for training, we didn't pay anything for the training because it had all been supported by grant funding. Yes, there is significant cost, but the cost has got to be offset about the potential benefits to your team, both in their knowledge and in their stickability. We didn't get a clear, significant sign, but our nurses were very grateful for ECHO because it demonstrated that they were working for a hospice which actually cared about them. And if you work for an organization which demonstrates that you care about them, it has an impact on the length of time you stay in that organization, which has in turn an impact on your HR, which has in turn has an impact on lots of other costs. So in a tight financial situation, ECHO is one way of really supporting your team and saving a lot of other costs. So I haven't answered your question because I don't have a concrete, you know, if you come to Northern Ireland, this is what it will cost, this is what it will cost to set it up. To run ECHO in our clinics, we have to have people having time to be in the clinic, and we have one IT person who is present during the clinic and one admin person with time to run the clinic. But they're also doing other things. So I'm sorry, that's the best I can do by way of an answer. Thank you.
Thank you very much indeed, Max. Some very interesting questions and useful responses. If you would like to join me in showing your appreciation, thank you for a very interesting talk.